Thank you, Jim. Thank you again for being able to speak here on this subject. So what I'm going to be talking today is about a qualitative penetration comparison between swept source and conventional OCT. Because we keep saying a lot of things about swept source, that it has a better penetration, that you see so much more, and all of these kind of things. But we need to prove that because you can say a lot, but you need the proof in order to really make those claims. So here, of course, you have the standard graph of the difference between swept source and spectral domain OCT. And Wolfgang had already shown a version of this graph, and it shows that the signal fall off in spectral domain when it goes through tissue is a lot less than spectral domain. So swept source has a much higher penetration. Now, this isn't only in tissue, this is also in any kind of media opacities. So be it cataract, be it uveitis, be it hemorrhaging, anything that makes an opacity is going to be easier to penetrate using a longer wavelength and using swept source technology itself. Now, again, this is very, very easy to say, but we need to prove it, and we need to actually demonstrate it. And with this in mind, Charles Reisman's group last year at the ISSOCT meeting presented a paper where they compared directly in healthy patients the penetration of swept source and spectral domain between the Triton OCT and the Maestro OCT. And they were able to show that both in the retinal and choroidal regions, the signal-to-noise ratio was much better using swept source. Also in the optic disc, the swept source had a much better signal-to-noise ratio and was able to penetrate much better. And also in the different layers, it was possible to get a much better signal using swept source. Now, this is, of course, a very, very important study, and it again goes to what we've been saying and what we've been claiming, that the penetration is better. The difficulty with this is that these were all healthy volunteers who didn't have any media opacities, and they didn't have any pathologies. So what I thought to myself in a relatively unscientific way, so forgive me about the unscientific nature of this study, was to take the same concept, take 30 consecutive eyes of 15 patients, and look at them with different machines. So on one hand, we would use a Triton, and then we would use other machines from other manufacturers that were spectral domain, and I wanted to see if there was a difference in penetration and visibility of the different pathologies using spectral domain. So again, we had all of these patients with cataracts, with intravitreal hemorrhages, subretinal hemorrhages, neovascularizations, cystoid macular edemas, subretinal fibrosis, subretinal SHREM, and pigment epithelium detachments. And I wanted to really visualize that the penetration is better if you use spectral domain. So what I'm going to do is I'm going to go through some of the patient cases with you just to illustrate the differences. So, for example, here you have a choroidal neovascularization, and this was a patient that had a cataract. And here you have the spectral domain image. And of course, you hear in the spectral domain, in the swept source. This is a swept source image. In the swept source image, you have a very good penetration. You have a very good penetration through the RPE, all the way to the choroidal structures, all the way to the choroidal scleral interface, and you can see directly through the entire structure. The same patient on the same day, using spectral domain OCT, you can see that the penetration barely gets through the RPE, and you see absolutely nothing of the choroid. And this is a very, very typical situation that you see in patients that have a certain amount of cataract. The same thing in this patient. Here you've got a patient with sort of a fibrosis or a SHREM beneath the choroidal neovascularization, and you can see that through the SHREM, in the swept source OCT, you can see right through the SHREM, through the choroidal structures, all the way down to the choroidal scleral interface. But in the spectral domain OCT, you don't see through. So you don't have a good penetration, and even in the other eye, where you don't have an opacity, you can see that the clarity of the choroid is much better using spectral domain using swept source OCT. Now, the question a lot of people ask is, okay, that's an unfair comparison that you're doing right here, because in spectral domain OCT, you can do EDI, or enhanced depth imaging, to get a better visualization of the choroid. The problem with EDI is that you then lose the quality of the image in the superficial retinal layers and in the vitreous. So using spectral domain, you have the quality of the entire image in one image. But nonetheless, I still wanted to compare EDI to spectral domain. So here you have a patient with a hemorrhagic PED. And you can see the hemorrhaging, you can see the cystoid macular edema, and with spectral domain OCT, you can see right through the hemorrhaging, you can see right through the cystoid macular edema, and you can see right down to the choroidal scleral interface. Now, using spectral domain OCT and having turned on EDI, you obviously have a little bit better visualization of the choroid than you would if you didn't use EDI, but still, the quality difference is really striking, because you have the entire pathology in one image here. In the EDI here, you lose a tremendous amount of information, and you don't even get that much of the choroid that you do in the swept source. Another example is this patient, and this also shows a little bit the limit of the penetration capabilities of swept source. So yes, it is. So here we have got a proliferative diabetic retinopathy with a subhyoidal hemorrhaging. So here you have this little bubble of subhyoidal hemorrhaging, and here you've got a much stronger hemorrhaging, and here you can see sort of the pool of hemorrhaging. And obviously, you can penetrate through the hemorrhaging using swept source very well, and you get all the way down to the choroid. But obviously, if you've got a very, very thick hemorrhaging, not even swept source is going to be able to penetrate it. So there is a limit to what a swept source can do. But nonetheless, even with this amount of hemorrhaging, it's fairly significant that you can get all the way down to the sclera. Now, if you take this and compare it to the spectral domain, so here you've got the normal spectral domain, and here you've got the EDI spectral domain, again taken on the same day. And again, just to be honest, I did not take these images, so I didn't on purpose make these spectral domain images look bad. But it was a difficult patient. The patient had bad compliance, and it was difficult to get a good image. But this was just the standard examination performed by the ophthalmic photographer, and this was also the standard image taken by the ophthalmic photographer. And as you can see here, we have a very good visualization of all of the subhyoidal hemorrhaging. At the same time, we get all the way down to the choroid. In the SD-OCT, you have the choice between non-EDI and EDI. In EDI, you get a lot more of the choroid, but not as much as you do here. But you lose all the information that you have in the vitreous. So you can really see the benefits of having the full information in one image as you do in spectral domain OCT. Now here's one of my favorite cases. This is a case with a polyploidal lesion. So you have here a large PED with a polyploidal lesion inside it. In the OCT, in the swept source OCT, you can see all the lesions fairly far down. In the spectral domain, whether you use EDI or not, you don't have the same penetration through the RPE into the polyploidal lesions that you want to achieve. Now, how is this clinically relevant? Because a lot of us have been trying to image polyploidal lesions using OCT-A, and it's proving to be a very big challenge. Now, with one of the new softwares we've put in, it's possible to manually resegment, and the segmentation self-propagates. So it's possible to segment these kind of polyploidal lesions in a different way in the OCT-A so that you can visualize them. But this means that we need to be able to penetrate through the RPE good enough in order to actually visualize it. And this is what happens then when you actually do that. So in this patient, here you have the ICG, and here you have the OCT-A that's been resegmented, and you can see every single one of these polyps is represented in the OCT-A because of the penetration through the RPE. And that's why we're able to visualize this in a way that hasn't been really very well possible up till now. So again, here you have this polyp, here you have this polyp, here you have this one and this one. So everything that's here is represented here. Of course, you need to understand how to interpret these kind of data sets. But again, you need swept source in order to succeed in this. So what is the clinical relevance of having this possibility? I've shown you a lot of cases, but why is it clinically important? For one, it's very important in uveitis. In this patient, we have a patient with a uveitis. You have cells in the vitreous. You had cells in the anterior chamber. So you had a lot of haze. You could barely see the fundus. But because of swept source, you can go all the way down to the choroidal scleral interface, and you can see the thickness of the choroid. Seeing the thickness of the choroid in uveitis is very important because the choroid changes thickness before the retina changes thickness. So evaluating choroidal thickness in uveitis is probably going to be a much more important indicator for retreatment and reinflammation than retinal thickness. So then you have to have something that's able to see through the vitreous cells and the anterior chamber cells and the haze. And swept source can do that. But more than that, because we have such an incredibly dense data set, it's possible to take a look at these single cells and actually in the future, hopefully, again, this is software that I built myself. It's not currently on the machine. This is software that I'm playing with myself as a research software. It's possible to take a look at these cells and actually visualize each inflammatory reaction to each one of the cells to get an objective cell count in uveitis. And you can, as you fly through this little arc here of the traction, you can see every single inflammatory reaction to the cells. This is something that can only be achieved using swept source because of the penetration, but also because of the scan density and the scan speed. Another example here, you've got a central retinal vein occlusion, and as you can see, even though you've got all of this hemorrhaging everywhere, and you have the hemorrhaging right here, you can penetrate all the way through to the choroid, but you can also see that this hemorrhaging isn't really having an effect on the quality of the OCT-A. Again, that has to do with the penetration capabilities of the swept source. Again, it's so good that you, in the CVG, or in the choroidal vasculography, even though we have all this hemorrhaging, we can even do a visualization of the choroid using the OCT data, again, because of the good penetration. And this is my last case. It's actually one of my favorites. So this was a patient that had a vitrectomy, and you can see that there was a hemorrhaging here, but below what we were peeling off, we found a melanoma. And there was hemorrhaging in it, and we did an OCT, and if you look at through the hemorrhaging, and it was very peripheral, so it was very difficult to get this image, but even though it was difficult and through hemorrhaging, we were able to see right through, and look at these little cells that you're seeing in this melanoma. Something that I am interpreting, I can't prove it, as melanocytes in the melanoma. But it's very interesting that it is possible to visualize this directly through all of these pathologies using swept source OCT, and that's one of the benefits of using it. So in conclusion, using this technology will really help you do penetration through very dense media and media opacities. Now, on the other hand, I have to say that this examination is a little bit unfair, because it's not homogeneous regarding how many oversampling you did. The data between the different instruments is not homogeneous. So we're going to repeat this test on the absolute raw data between a Maestro and a Triton, like Charles had done before, in a clinical setting where we do all the pathologies, and then we'll have a quantitative comparison between spectral domain and swept source. Thank you very much for your attention.